I do believe that if you can do an anatomic and restore the anatomy perfectly, that is a superior operation. For me, because it's the same operation, if I'm doing a total shoulder or a reverse, it's exactly the same operation. Now, selecting which osteoarthritic is going to get a reverse and which is an anatomic, it's difficult. And I do believe that if you can do an anatomic and restore the anatomy perfectly, that is a superior operation. But that's not always technically feasible, and it might not be always worth the benefit of achieving that because there might be other factors. If you have an 88-year-old patient that you can do an anatomic on, but you realize if you do an anatomic, there's some potentially increasing risk in the short term for subscapularis dysfunction or something, you might question why would you take that risk when you can minimize that risk by doing a primary reverse when it's very likely those patients will get a substantial clinical benefit. Let's say you have a patient who's requires their arms to do weight bearing because they need an ambulatory device. Maybe you could do a subscap sparing. I don't know, but you'd really want to have something that would be durable. And anatomics probably don't allow that at this point, but maybe they will over time.